So hello everyone, my name is Yasmin Razak. I'm a GP in West London CCG and clinical director of a PCN called Neohealth. And my role is to ensure our patients get the vaccine in the vaccine centre. And I'm currently running one of the vaccine sites at St Charles with my colleagues in West London.
I'm Hella. I'm a GP registrar working in public health at the moment and working on advice for the COVID vaccine.
Okay, great. And Dr. Budd?
Hi, my name's Will. I'm a clinical research doctor at Imperial, working on the Oxford Imperial and Janssen vaccine trials, and I also do some media work in the US.
Great. Okay, thank you. I'm actually going to take this holding slide off so that we can just see everyone's faces. And I'm actually then going to take my face off because it's far less important than you three. So I'm going to go off camera, but I will play MC if you like. And I'm going to ask our top 9 questions that we compiled. I know it's a weird number 9, but we couldn't quite get the 10th one. Then we figure better to give you guys a chance to ask your questions than try to squeeze in a 10th one. So let me go off camera here. And I hope this stops my video and not yours. Yes, okay, I think that was successful. All right, so first question is for Will. So what are the main differences between the different vaccine types? So what's the difference between a viral vector or an mRNA vaccine, for example?
Good question. So we'll start off on what a mRNA vaccine is, which is, for example, be the Pfizer vaccine. So I'll explain what mRNA is first. So if you imagine in your cells, you have the brain part of your cell, which we call the nucleus, and we can think of this as how a car and the car factory would work. So head office have all the instructions on how to make the cars, and your cars are made at the factories in different parts of your cells. So the nucleus, the brain, is the head office, and it has the instructions to make the cars. mRNA is a message that sends to the factories to make cars. So what we do with this vaccine is we give you this little bit of information that goes straight to the factory part of your cells. So it bypasses the nucleus, so it doesn't change any of your DNA. It just goes straight to the part that makes proteins, and there is where the vaccine works. And that works by making little parts of the virus that are normally on the outside, so your body recognizes it. A viral vector is similar to when we think of the myth of the Trojan horse, which is what we hide inside a very weakened virus that normally would cause a cold in, say, macaque monkeys. Inside it, we hide tiny parts of coronavirus so that when we inject it into your arm, your immune system fights this virus that's very weakened, and at the same time, without even knowing it, fights the coronavirus parts that we've hidden inside. It's important to note in terms of both vaccines that neither of them can actually cause an infection. They just show you what the outside of the virus looks like. So if you come into contact with it in the future, your immune system recognizes it and can easily fight it.
Okay, that's brilliant. Thank you. I have just been informed that when I speak, it just goes to a weird thing that says myGP on it. So I've decided to turn my camera back on to ask the questions. Thanks, Will. All right, that's brilliant. So, second, actually, Will, I think you're up for the second one, and then eventually we will, maybe I'll mix these up. Let's do that. So Yasmin, okay, how bad are the side effects and what do they tend to be?
Yes, so I mean, the side effects are, I would say, a really positive thing because it's a sign of your immune system really kicking in and showing you that the vaccine is working. They last about 2 days. Some people don't get any side effects. I had a really achy arm for 2 days, and that was really it. Some people will, however, get some fevers and some chills and some fatigue and maybe feel a little bit sick. And paracetamol should be sufficient, but you may want to plan your vaccine around, if you're a busy working person, around your working schedule if you do get symptoms like that. If symptoms go on for more than 2 days, it can go on for up to a week, that's absolutely fine. But if you do have symptoms of a high fever, a cough or anosmia, of course, that's query COVID, that's completely separate. And just be mindful, if you've got a really high fever, especially day 3, you must, of course, speak to a GP, but otherwise generally mild. My advice is pick the arm that you don't sleep on. I picked my right arm the first time, but I couldn't sleep for 3 nights. My second vaccine dose, I'm going to pick my left arm.
And does it worsen with the second dose? Do symptoms tend to worsen and side effects tend to worsen?
I guess we don't really know yet. We haven't done many second doses, so we don't really know yet. But I would say, anecdotally, what I'm hearing is potentially it could be, but definitely, you know, keep some paracetamol and fluids. I think that's the safest thing to do. But generally, most people are absolutely fine. And again, side effects are a sign of the vaccine working, which is a really positive thing to have.
Brilliant. Okay, thank you. Will, sorry, you're back on deck. You're back on deck. Abby, we will get to you, I promise. But Will, since you've just gone through the different vaccine types, there was a specific question that has come up quite a lot, which is, does the Pfizer vaccine change your DNA? I think mRNA is a little scary. So can you explain that?
So yeah, that's the mRNA type vaccine, as I explained. So the different parts of your cells, so the DNA is in the nucleus, and it sends a message, which is what RNA stands for, messenger RNA. So it doesn't change your DNA, it doesn't enter the nucleus, which is where your DNA is kept, and it's kept safe in there. So it just affects the outside parts of your cells, and all it does is just simple instructions on what your cell can do. So it doesn't affect the DNA at all, and there's no way it can change your DNA either.
Okay, thank goodness. All right, next one up, we're going to bring Abby in. So Abby, there's been a lot of chatter about pregnancy, fertility, and other things. So this is kind of a combo question. I suppose we could have got our 10th question, guys, but let's keep it to a combo. First of all, why are pregnant women and under 18s not allowed to take the vaccine? And the second question is along the pregnancy lines, do any of the vaccines have any effect on fertility?
Okay, so with regards to pregnancy first, as with most pharmaceutical products, specific clinical trials of the COVID vaccine in pregnancy in children haven't been carried out. But none of the data that we do have indicates any harm to pregnancy, but they don't have enough data yet to routinely recommend it in pregnancy. But similar style vaccines are given in pregnancy all the time without any harm. And actually a new US study has come out this week, and they've seen that it's been given to 20,000 pregnant women with no safety concerns. And that evidence will be looked at by the UK, and we can incorporate that into our guidance. Actually, the Joint Committee on Vaccination and Immunisation, the JCVI, say that vaccination in pregnancy should be considered if there's high risk of exposure to COVID, or the woman has underlying health conditions that put her at high risk of serious illness. And in those cases, you should speak to a clinician and discuss the risks and benefits of having the vaccine. With regards to children, the vaccine trials have only just begun in children. So at the moment, we still have limited safety data and limited data on their effectiveness. And as children have a very low risk of severe disease with COVID, at the moment, it's not routinely recommended for children under the age of 16. So the Pfizer vaccine can be used in those children in at-risk groups from 16 years and above. There are certain circumstances where it is recommended to give children below 16 but above 12, such as those with high-risk neurological disease, or if they're living in a residential facility, but that's a bit more specific. In terms of fertility, the Royal College of Obstetricians and the Royal College of Midwives have put out a statement that they want to reassure women that there's no evidence to suggest the COVID vaccines can affect fertility at all. And there's no mechanism that makes scientific sense for how they would affect fertility. But for those that are pregnant and worried about the vaccine, they've put out a really great leaflet that answers all of those questions and worries. So you could share that with your patients if they are expressing any of those. And Public Health England have a similar leaflet, and that's available in many languages, depending on who you're speaking to. So we can share those with you.
Okay, that's brilliant. So when we share this link round after the presentation, perhaps we'll include some of that as well. Great. All right. Thank you, Abby, so much. Sorry it took so long to get to you. All right. So next question. Will, we're back to you, I'm afraid. How and why was the vaccine developed so quickly? I think there are some concerns in the public about speed to market and should they trust it having been developed so quickly. So what would you have to say about that?
Yeah, so I'll talk about first what normally is limiting in how quickly we can get drugs to market and why that's different in terms of a vaccine. So one of the main problems we have in terms of developing drugs is, first of all, the number of volunteers on the trial. So to prove something safe, you have to either vaccinate in this case or in drugs, give the drugs to a certain number of people. And in this case, we didn't have any limits really on volunteers. People came forward in their thousands. So we reached that target of the number of people you have to give the drug to quite quickly. And that's around 10,000 for phase 3 trials trials. And for instance, the Oxford study used 13,500 participants, so above that. Another thing that we have issue with is money. So developing a drug costs a lot of money. Often you pay the participants, you have to pay the doctors and nurses and the research scientists, and you have to make the drug and things like that. But again, in terms of the COVID vaccine, people want the COVID to be over. They want to save lives, want to go back to normal. So there's been lots of money coming into it. Luckily, we had done research previously on, so there's been previous SARS, which is very similar to coronavirus, also as we know it's called SARS-CoV-2. So we've done previous work on SARS and MERS, and there's been lots of developments in vaccines recently, especially this mRNA technology, which is new. So we've adapted some of that, and one of the benefits of mRNA technology is that you can change it very quickly to suit or to match whatever virus that you're trying to vaccinate against. So we already had the work done. We had the groundwork and the foundations, and we were just building on that slightly. So, it's been quick because we've had the money, we've had the resources. There's lots of people working right across the world. We've never seen quite so much collaboration internationally as well as internally in terms of things like this. So, as soon as sequencing of the virus happened, it was shared all around. As soon as the vaccines were proven to work, they shared data. So everything's just sped up by people working together and the amount of people involved, which is really good.
It's been such a, I was on mute. It's been such a tremendous worldwide effort. It's actually, out of all of this, when we're all looking for a few positives, that's one of them, isn't it? Just everyone working all together and creating something really special. Thanks for that, Will. Okay, so the next one, I actually think, Will and Yasmin, you might want to kind of tag team on this one, but there's been a lot of questions around the survival rate. So if we've got a 99% survival rate with this virus, why bother with a vaccine? And I'm gonna throw it out to you and let you guys fight over who wants to answer this first.
Yasmin, you can start.
I was getting distracted by your cat there, actually, in the background.
I'm noise of doing this from home. If I attempted to lock him outside, he would scream outside the door. I couldn't hear anything.
Okay, I think that's a really important question. I have heard that question come a couple of times for those who really don't want it. And I think in terms of, I think it's about perspectives. And yeah, it's really reassuring to know that only a certain proportion of the population pass away from COVID. But there's something about what we know is about the spread of the disease, and we may catch it, we may survive, but of course we know that we may give it to someone else and that may multiply, and on it goes. And we may then be responsible for the death of someone else down the line without even knowing it. And that's hard to see and imagine, but we know that's the reality. So I guess, our civic duty is, if we're well and fit and healthy and able to take it with no side effects, then it's the opportunity to really, get back to a normal life for the rest of society and those who are most vulnerable. And so many people, as we know, maybe amongst our audience, amongst our friends and family, have been at home for the past year. So when I'm at Vaccine Hub, we're now doing the shielding cohort. And that's a patients who haven't been out for nearly a year. As their first trip out is actually to get their vaccine. They've literally been at home in their rooms and keeping themselves shielding and safe. And so it's something about getting back to, we always say normal life. I don't think life will ever go back to normal, but, going back to life of some form. And I think the other thing to think about with the COVID itself is the other impacts. So if one person has COVID, another person has COVID, the hospitals are getting full of COVID. Well, what happens if you have a road traffic accident or you have a heart attack or a stroke? Well, where do you go? Well, unfortunately, there may not be anywhere to go. So in the peak, as we saw, there was a very high risk to patients who couldn't get in. We have to also now think about cancer and screening, what's happening with that, because all the resources in the NHS are having to go towards the ITU for COVID. So if we are of that 99% who may get COVID, we still may end up in a hospital, and those beds may not be available for us when we need them for other health conditions, and that's a real risk. And we're finding people having to go to ITUs in other parts of the country to get in if they normally would go to their local, because of the impact of that, and that impact probably isn't as visible as a death. And the other thing we probably don't understand enough of yet, although there's a lot of there's a nice guideline that's come out now and there's clinics set up, is this concept of the long haulers, the long COVID. It's quite significant. I had it. We were talking to some professors about it. We said, there's a medium COVID as well. Some people will recover at certain times. So I think mine was a medium COVID. I had it for about 7 months and I had periods of breathlessness. and I had complete fatigue, mild fevers. It wasn't COVID, but it felt like COVID again. But some people are having more than that. They can't run anymore. They can't get out the house. They're struggling with COVID. COVID has, for some people, a larger portion of people, long-term side effects, and those are unknown, what that means long-term. And that's quite scary, a lot more scary than a little vaccine in your arm. And I think that's something to be mindful of. And because, we haven't really quantified it yet, we've just, given it the label and started getting the diagnosis done. So, and the impact of that on our society and our jobs and our economy, because it's hitting lots of working people, is massive. So I guess if we're in that 99%, so lucky, we're so grateful not to have that horrible endpoint of, not making it and not being here anymore. But the wider impact, I would say, is something we should be mindful of. And again, the only thing I would say is, I guess I'll hand over to Will, actually, at that point.
Pretty much said everything I was going to say.
Good luck. That. Okay, well, we can move on. If I had no doubt Yasmin would be very thorough. So, Will, I don't blame you if you've got nothing to add.
No, absolutely.
That's fine. Okay, Abby, back to you. So there's a question about why patients have to wait their turn. So can you kind of talk us through the reasoning behind the staged process and all of that, please?
Yeah. So the JCVI, the Joint Committee on Vaccination and Immunisation, they determined the priority groups for receiving the vaccine in order to protect those that are at highest risk from serious illness or death. And all the evidence from the UK indicates that those over the age of 65 years have by far the highest risk, whether or not they have underlying health conditions, and that risk increases with age. And residents in care homes for older adults have been disproportionately affected. Then the reason for including frontline health and social care staff is to protect workers who are at high risk of exposure, and they are caring for vulnerable people. And so vaccinating them may help reduce transmission. In terms of the delay to the 12 weeks and why patients have to wait longer than expected for their second dose, this decision was made so that we could protect the largest number of people as quickly as possible, and therefore reduce the burden on hospitals that are at risk of becoming overwhelmed. And actually, there's now really good evidence that the 12-week schedule gives a strong immune response, particularly for the Oxford AstraZeneca vaccine. And there's good evidence that you have strong protection after the first dose of both that will last those weeks to protect you until the second dose. I think the World Health Organization has recently come out in support of that and advising that as well.
Do we know what this is probably a question for Will, and it's not in our top 10. See, I'm going off script. Will, do we know what the protection rate is after a single dose of Oxford vaccine, for example?
Yeah, so it's very similar to the protection rate of the booster. So when you think of vaccines and why you use two, so the first one is to show your immune system what it looks like, and your second one is to hold it in long term, and that's what we think. So the first dose is pretty much the same as the second dose over at the beginning, and then it will drop down after a certain number of weeks. So it is just as effective as one dose. And there are other vaccines, such as the Johnson & Johnson vaccine, which is now what I work on, which is the Janssen study. That is actually designed to be used as a one-dose vaccine as well. So there is evidence to suggest that one dose is enough, but obviously when we've done the trials on the other ones, 2 doses is what we've shown to be slightly more effective.
Okay. Right. Well, Will, I'm going to stay at you for our last one. We got to 10, actually. Here I was going to say our 9th question, and then I got us there in the end, but just by being nosy. The last question that we've got, again, is for you, Will. Are the vaccines effective against the new variants? What can you tell us about that? It's a big question for everyone.
Yeah, this is a good question. So as we know, variants, they're quite new, and how we discover variants is that we do lots of genetic mapping of when we get swabs, positive swabs, and it's really good. It shows how good the UK is at surveying to see if there is new variants, that we discover quite a lot of them here. Now, in terms of looking at vaccine effectiveness, you have to do that once you've discovered the variant. So if it's only just been discovered, it takes a while for us to determine how protective it is. And what will make a variant escape a vaccine is if it changes significantly enough that it doesn't look the same as what our vaccine is designed to look like. So there is evidence that across the vaccines that they are protective against a variant. So for instance, in Moderna, they did do a study in South Africa as well, and that proved that it was effective against the South African variant as well as a UK variant, similar to Pfizer. Oxford, we've been shown that it is slightly less effective, but it's still effective. And that when you think of how a vaccine works, there's multiple ways it works. So it can reduce transmission, so it stops the spread of the disease. But ultimately, a vaccine works by protecting whoever then becomes infected with a disease from the outcomes. So the outcomes in this sense, as Yasmin alluded to earlier, so not only is death, but other things such as infection that lasts a long time, long COVID, putting you in hospital, things like that. Now, the vaccines against all the variants still stop serious disease. So that what I mean by that is, stop you going for the ITU, stop you from dying, stuff like that. It's that you may still get symptoms from the South African variant in some of the vaccinations, but that doesn't mean that it doesn't work. It just means it's less effective at stopping that minor disease. So they have been proven to still stop death and to stop hospitalisation. It's just that the effectiveness of stopping transmission, we're not too sure on. But the variants at the moment aren't too much of a concern in terms of escaping the vaccine. The vaccine's still working, protecting you. So
the message is that any of the vaccines currently on the market will still protect you from dying or from putting serious unnecessary pressure on the NHS, including Oxford. There's no indication that that's no longer the case. Okay, thank you. I think, believe it or not, that's the end of our 10 questions. But before we go to the Q&A portion from the audience, the private session that no one else will get to see but us, Yasmin, do you want to just let any of the patients who may be watching this in the future, could you let them know how best to book in and how that process works?
Definitely. Okay, so the COVID vaccine is being delivered in different places, as we know. So hospitals are running it, community clinics with your own GP are running it, and also there are mass vaccination sites everywhere. So there's enough vaccine for everyone when it's your turn. There is a website that you can go and you can book. There is a phone number as well. I think it's 112 possibly. Of course, to book an appointment with your GP, you just ring your GP surgery. We've got plenty of vaccine and we are full time to ensure you get it. We do also have community pop-up clinics. So I'm running one tomorrow in my own surgery. So my patients can come to my surgery, and lots of GPs are doing that as well to make it more accessible. And if you can't get to us, for any reason at all, especially if you're really worried about getting out of the house, and we know that, then we can get to you. So don't worry, we are here to get you your vaccine. I think the important thing is that we will ask you some screening questions. So this call is for the admin staff and patients. So to think about what questions that you need to ask or you will receive. And I'll just read those out now. So have you had a vaccine in the last 7 days? It doesn't mean you can't have another vaccine. It just helps us know in terms of discussing your side effects with you. Because I guess if you have 2 jabs, you may have a little bit more. Do you have a fever? If you have a fever at the moment, we wouldn't want to give you a vaccine, obviously. And do you have any symptoms of coronavirus? We'll ask you those questions. Have you had any serious allergies to the ingredients of the vaccine or drug or any other vaccine? And it maybe we suggest that AstraZeneca is a preferable choice if you have serious allergies, but your GP or your specialist will discuss that with you, because the Pfizer is also very safe as well. Have you had any unexplained anaphylaxis? So that's if you've had an EpiPen, and you would know if you had an EpiPen, you carry one around with you. And if you have, again, we would suggest you discuss it with your doctor and go for the AstraZeneca as an option. Have you been in a trial of a vaccine? It doesn't mean you can't have the vaccine, but again, we need to know. We asked if you could be pregnant. And the only other one we want to know is, are you on any blood thinners? Again, of course, you can still have the vaccine, but we just suggest you put some pressure on the arm with any injection as standard for a couple of moments, because that's normal. And then, you have your first dose as soon as you get it, and your second dose within 12 weeks. We will let you know when your second appointment is. As soon as we know, we will let you know. You do not need a letter if you are over 70 or in the shielding category to book your vaccine. You just give us a call and we will book you in. You do not need a letter. We'll be going down the cohorts very soon. So next week, it will be over 65s and on it goes, and it will be quite quick. So just look out for a text message or a phone call from your doctor when it's your turn.
And thank you so much to all of the panelists, to Yasmin and Abby and Will. You guys are brilliant.
Thank you.
Have a great day, everybody. Thanks so much.